So we've discussed the issues. People have implied or inferred or even directly approached some approaches to solving the problems that we're confronting. And again, I would suggest that while we have a chronic disease known as medical shortages going on the background all the time, we're really focused here on how do we address shortages that are inherent to a disaster event, and those shortages that will mitigate our ability to effectively meet the patient care needs. My personal view is we're not going to be able to do that without dealing with the fact that we've got a chronic disease going on if we're going to maximize resiliency. The folks in this panel, and Erin Fox is going to lead us through this. Erin works at the University of Utah and coordinates that famous database that you heard about yesterday from Doug Throckmorton to some large degree. And she and her team up here, I think, are going to try and address what can we do to strengthen our predictive potential for addressing these issues. So I'm going to turn it over to Erin, and you and the team lead us through this. Thank you.
Thanks so much, Admiral. So I am really excited about our panel today, and even more excited about the topic, because we've heard a lot about how drug shortages impact clinical practice. And so wouldn't it be great to be able to predict those shortages and have more definite plans in place to really prevent the impact to patients and clinicians. And so today I want to introduce our panel. I'm going to start with Amy Kircher, who is Assistant Professor at the College of Veterinary Medicine at University of Minnesota. We have Danny Peters, President at Magnet Strategy Group. We have Julie Swan, I didn't mean to skip over you there, Department Head and A. Paul Allison Distinguished Professor at North Carolina State University and co-founder Center for Health and Humanitarian Systems at Georgia Tech. And then last but not least, we have Alida Roth, Burlington Industries Distinguished Professor, Supply Chain Management at Clemson University. So, I think I really want to capitalize on the broad and diverse perspectives of this group and how we can really think about how can we predict these shortages? Is it even possible? And if it's not possible, what are those gaps in the data that we need to fix? So I'm going to open it up, and does anyone want to start first?
Sure. So Amy Kircher, University of Minnesota. I'm not a veterinarian, nor do I really work in the vet school, so that's sort of a misnomer. I have multiple jobs, multiple personalities, as many of you probably do or know that happens in the university. I am a recovering prior wanting to get back to a government official. So I come with the perspective of how do we need to find operational solutions to some of these challenging problems. And what I would argue we have is these predictable surprises. Max Bazerman and Michael Watkins did this work at Harvard. And it's really those things, right? The Challenger, it's other things that we know that we could predict that this is going to happen. Puerto Rico is a predictable surprise. I would argue, after listening yesterday, Brexit is a predictable surprise for drug shortages. Who is doing that analysis now, and what are those cascading effects that are going to come from that? That's what we should be working on now, because that's where we get to this predictive nature. So we've done some work, I as an epidemiologist, and then in partnership with the UN, with the funding from the Paul Allen Foundation and disaster response, and looking at things like Ebola. And when we all come together, this is the example of when a disaster creates a shortage problem. There's also shortage problems that create disasters, so it goes both ways. How do we look at how we're constructed, how we communicate? So much about information sharing has been brought up. And so I think we need to continue that conversation, because that's where we get to the predictability and the analytics behind it. So from the disaster perspective, I'll talk about both the disaster perspective and then a current crisis. One, from the disaster perspective, how do we get the right thing to the right place at the right time in the right quantity, right? And so that's some of the issues that we face with Ebola, with Puerto Rico, with some of the other ones. But one, there's a lot of work we can do now. We need to understand what's the population. Who there is going to need what thing? That's known data. How many diabetics do we have? You know, what information do we know about the pediatric population? We have profiles, so we know that when a disaster strikes, what this community is going to need. Secondly, I think we need to know the infrastructure that we're receiving into. Receiving into Fargo, North Dakota is very different than receiving into New Orleans, is very different than going into Sierra Leone. So what infrastructure is receiving said supplies, and then can they handle it, and do we need to reinforce their resources, whether it's manpower, funding, other infrastructure? And then being inclusive of all players. This is really, right, what we call a team sport, I would argue. And as we did the Ebola work, what we learned from the manufacturers is they're like, we want to be part of the solution. So here's what we're willing to do. We will acquire raw materials so that when you tell us to surge, we're ready. Because if you just say, surge tomorrow, that's not happening. Well, what they need then from those infectious disease or public health people is they need to know when something's emerging. When is it going hot? Well, those communities aren't willing to share that information. So the private sector is stuck at a loss saying, I can't surge or prepare to surge at my own cost even, if you don't tell me that something's coming down the pike. So I think there's some interesting there. So I would argue in this disaster perspective, right, there are some tools that we need to develop that are operational and can be deployed. And then really importantly, that has to accompany them are policies and procedures. And what are those triggers? So at what, you know, the industry's not going to share all their information right away, but if there are certain triggers of disaster, they are willing to share. So let's set those triggers. When we reach X amount of issue or problem or need, you know, then yes, then we're willing to tell you how much we have and how much you can get and what we're going to charge for. So let's work on those policies and procedures. I think the other thing when we now, if I shift just from disasters to predictions, we've done this work in food already. So one of my jobs at the university is the director of the Food Protection Defense Institute, and we look a lot at counterfeit. Well, I can tell you, because of Ebola, we've got counterfeit cocoa coming into the United States. And people go, what? How do you build that bridge? The data's there. We just need to put it together in a more meaningful way. So because there is cocoa in the area where we have Ebola, there are public health restrictions of movement. People can't travel as far. So they're not harvesting, which means there's less cocoa coming out of the area. Well, that increases prices. So guess what? People who already have cocoa and want to make money are diluting it with husk, with arrowroot, and with dirt. So they're extending the cocoa and shipping it into our country because they can make more money, right? So because of Ebola, we have crappy cocoa. Like all of these predictable surprises can be uncovered, but we need to put data together in a more meaningful way. I would argue it's the same with supply chains related to drugs. So I think, you know, this whole, yes, we need more data. We need to access more data. The data's there. I think we have a bridge building problem. How do we build the bridges better so that we can move the data around in a trusted way where people feel secured about how it's being used? Obviously, we need to map back to source. What are the raw materials? Map the production capacity, right? So we know that Puerto Rico was a fail point. And then look at our threats. So what are the things that will threaten this? So natural disasters, trade, tariff policies, Brexit, all of those things are these threats that will be put upon our supply chain. So if we know that, and then we overlay, like we were talking with Özlem, you know, if we overlay some of her framework, then we can better model and get ahead of a shortage curve in the point where decision makers are making mitigation steps and not being reactive to shortages. So I would argue there's a bunch of work to be able to do in all of those spaces to get us to prediction.
That's great, and thank you for those comments, Amy. Yesterday I was struck by the real extent of the shortages, and I think if the American public knew, then they would demand action, because it's just appalling the number of providers on a regular basis who are having to provide a secondary or non-preferred form of care. I do think that we can do better, and I have a couple of suggestions, and some of them are similar to Amy, but I think it's still worthwhile pointing out so that in the report of the workshop, there's some real emphasis on some of these things. And I'll divide them into a couple of different areas. So in everyday chronic kinds of shortages, which can be driven by disasters, natural disasters or others, but there I think is where the visibility of the information and the transparency is very important. In supply chain classrooms, we use a game called the beer game. And the beer game is not a bunch of quarters in a glass, I can tell you that. But I love the electronic form of the beer game where you can play the version where everybody in the room has an agent to be in the supply chain and they can make all of their decisions and they wind up with a lot of shortages. And then you play the version of the game where they can see the full information in the supply chain. The demand at the retailer, the level of inventory at the wholesaler, the distributor, the factory, everybody can see everybody's decisions. And the next layer that you do is also where people are co-located so that they can coordinate better across that supply chain. And you see a huge difference in performance of the supply chain from that data visibility. And I'm talking about the level of inventory in hospitals and pharmacies, the level of inventory at wholesalers and distribution centers, all the way back up to the factory. And so someone has to ensure that there's trust and willingness to do that. And all of that, but also have the manpower to look at that data and to really think about that data. And so I do think that our predictability would improve and our ability to manage shortages would improve if we could get to that level. The second area where I think we can make improvements is related to major disasters or disruptions in the supply chain. So certainly Maria is a good example of that, but there are others upcoming that you mentioned. And for this, I think that you have to have a good map of your supply chain, the mapping of your suppliers and your providers all the way up to the API, and to really understand what are those at-risk supply chains, either because they have a lot of manufacturers in an area that might be disaster prone, or because if an earthquake happened, you wouldn't be able to transport between two different parts of the country. So you really have to do that mapping all the way upstream. So that's the second area of data and information that I think will ultimately help us be able to predict shortages even before they're occurring so that we can manage them better. The third area I think is on disasters of a different nature. It's more like the Ebola and Zika examples where we're not necessarily facing those diseases on a regular basis in this country, but the potential is there for it in this global world where everything's interconnected and there are new infectious diseases popping up, especially with respect to the animal-human interactions that are happening. So we really have to be thinking about what are those larger threats that could occur, what supplies do we need, and certainly the strategic national stockpile is an element of that. But I think that it's very cost prohibitive for that to be the only supply of stockpiles throughout the country. And so if everyone had a good understanding of what those potential threats were, then they could better plan their inventory and they could better come up with frameworks for storing and managing that inventory, where it may not be that you have the supplies at every hospital for 96 hours because there's not enough space, but rather you have some other kinds of arrangements, perhaps with some of the private sector partners. And then I think the other thing, so one of the areas around prediction is around better data and visibility of those different types, but I think it's also important to understand the cascading effects in the system. Some of the cascading effects are within the supply chains themselves, but there are other kinds of cascading effects as well. I think that the example of the IV bags yesterday was a great one, where first the shortage was on the 50 milliliter size, and then it was on the 200, and then it was on the 500. So you really need to understand substitutable demand, and that can be done at a national level so that each individual hospital and each individual pharmacy is not having to do that, so that we can say, okay, well, we are currently experiencing this shortage, but we expect it to also impact these other products in the coming weeks or days. And so that's some of the types of data that will enable prediction, but I think the other critical thing is who is going to be doing that prediction, with what resources are they going to be doing that prediction, and then how is that data shared. And then I know this panel is supposed to be prediction, but I just want to point back to the fact that with prediction and management, we're just in some ways putting Band-Aids on the problem. So we also need to make sure that we have a good understanding of the root causes so that we can prevent and prevent future shortages by predicting that those would occur. And some of those are market forces and reimbursement policies, and it's going to be quite painful to solve those. It's going to increase costs, but we also, if we fully understand the costs of managing shortages and predicting for shortages, then we can better justify those other kinds of solutions.
That's great. Alita, do you want to build on that?
Might as well get the academics of them. But at any rate, I want to pick up on what Amy talked about. Am I on? Oh, good. Okay. I kind of want to pick up on what Amy and Julie had been speaking about. And I'm looking at kind of reframing some of the issues that we've been talking about in different ways, just so I can throw these things out. First of all, I worry about substitutions because substitutions can really change your real demand. And I remember a story when I was in a doctoral program, I never forgot it. You're the last person on the airport, in the airplane, and the final food that's delivered to you when they used to do that was peanut butter and jelly. Well, I didn't really want peanut butter and jelly. I would have preferred the steak. But at any rate, so when they place the orders, they keep cascading and making false orders rather than what the true demand is. So I think we have to be very careful, and I would argue that we would need a real database on substitutes. When substitutes were used, that we keep records, detailed records on it, and also that might also have a cascading effect on readmissions. I mean, I can tell you a personal example. I had taken a drug that was a generic drug, which is always prescribed to you. I was almost admitted back to the hospital. It turned out that the name brand drug, which was more expensive, was fine. And it really scared me, and I started looking into this. So substitution is not always substitution, because the coding could be different, and also the binders can be different. So again, this is part of the prediction process, and it goes back to the earlier points about understanding data. The second point that I want to talk about a little bit is this issue about supply and demand. And when I talk about reframing the problem, I worked in manufacturing and supply chain and with drugs and foods for many years, and we looked at quality risk with FDA data, which took forever to get through Freedom of Information Acts. But anyway, we got it, and we found that there really is quality risk when you offshore to Puerto Rico even. And you know, who would have thought of that? Now we're offshoring all over the place, and we talked about it yesterday in terms of China, India, whatever, and you have no clue how much, what you're getting in some of these products because we don't test them for some of these issues. So we have to really worry about it. And I'm not even talking about what you get in it. I'm talking about processes that you get through the FDA data in terms of action reports, trends, and those things, which was our measure of quality risk. So that was a big issue. So the supply side is really what everybody's been talking about today. I think we also should begin to look at the demand side from an individual, I call it citizen level. And so I reframe my doctoral student, Grace Tanathan, from her dissertation, she's at University of Maryland right now. We reframe the problem to look at it as a service operations problem. And so if you look at it as a service operations problem, then you have people in the co-production process. So we said before the flood you have a citizen who has to be prepared. During the flood you may have a victim. At the end you have a restorer. So the citizen has multiple roles during that process, and we were fortunate enough to get 43,000 household data from the 2011 surveys that were collected by the Thai government, and very extensive surveys, personal survey, because you can't send a survey out on this nature. And and so we have data before, during, and after the flood, and we found some really important things that you all know, but we have data to prove it. If you prepare, the multiplier, if your household prepares, the multiplier effect gets to, you're not, during the loss, controlling for severity of the flood and all those other types of things, that has an impact on your final ability to recover from a financial point of view and also from a wellness point of view. So that sounds trivial, doesn't it? How about the quality of the warning systems? The quality of the warning systems, making sure that individuals have access to it and also that they reach the populations that you're interested in. And we found that too carries through. Now those are public kinds of things that can be done, right? In terms of education, getting local communities, we found ties, community ties make a difference. So what I'm saying is at the end of this process, now this is surge demand for perhaps drugs and pharmaceuticals, but the idea, if we could reduce that population that actually needs those things, right, then we save it for those critical, especially in shortages, in a disaster situation, you're going to have all kinds of unexpected things, as we've talked about. But if we can reduce what we need by doing some what I call fairly simple things, right? The other piece that's coming up, I was doing some work on collaborative the sharing economy, and there are all kinds of community groups out there and social media that are, working with neighbors and neighbors. I mean, I remember the neighborhood watch, when I was younger. But basically, where people knew each other, you knew what to do. So there are all kinds of things going on that might change how we begin to think about our approaches, that we can actually begin to reduce demand. And what this suggests is what everybody is saying. It's a very complex problem. It's a systemic problem, and we need balances across. Now, when we do that, one final thing, and then I'll quiet. We always talk about metrics. I've been in data for too long. I won't even tell you. But my point is, when we're talking about metrics, everybody has a different language for things. And Julie talked about, making sure we understand what people mean. But I remember teaching a case when I was doing work in knowledge management, knowledge sharing, the Taco Bell case. And if you want to talk to the employees, you don't talk about finances, you talk about tacos produced. So the language, if we go from epidemiology to manufacturing to healthcare, the language is different. The symbols are different, right? The mnemonics. So we have to really be very clear and understand and be able to share across and communicate the right things. So that's kind of my...
Thanks, Alita. I really like the way that, as Amy spoke of, what are the knowns? Some of your information really applies to that, really identifying in the community what are the knowns, to use that a little bit to predict what will your demand be. That's great. And then I really like your comments on the quality issues, quality in medications and quality in manufacturing is so important. And certainly there have been lots of ideas thrown out about how quality metrics, maybe a star rating for manufacturing, so that hospitals could maybe purchase based on quality, make those quality-based purchasing decisions. To Julie's point of getting at the root cause of some of this, understanding more of the quality data might actually, could predict some shortages if you know a factory is in trouble early, but it could also help prevent. But I'm really interested to hear what Danny has to say.
I come from a slightly different perspective. So my background is that I work with companies that have manufacturing technologies that enable rapid scale-up of medical countermeasures in the event of emergencies. But I also, on the advocacy side, work with the Alliance for Safe Online Pharmacies, and it's a nonprofit global organization dedicated to protecting the public from illegal online drug sellers and the integrity of the supply chain. And I've worked to set up their chapter in Canada. And third point is I am Canadian, and so I speak to the work in Canada being done on public health and also on the drug shortages issue. So one of the things I want to talk about with respect to prediction is thinking about the consumer, but on your point about the individual, that scenario, if an individual goes into hospital or in pharmacy and learns that there is a shortage and there is an emergency, what are they going to do? Well, everyone has one of these. They're going to look on their phone. And you'd be shocked to see if you look at even drugs that are on a shortage list, and we've done this ourselves with ASOP, we looked for drugs that are on the shortage list and then did some searching on the internet, and we were shocked to see how easy it was to access medicines, and most sites, 96% of online sites, are actually not operating inside the appropriate rules and regulations. So I think we have to think of that scenario, and we did have an issue that came up a couple weeks ago in Canada we have a shortage of the EpiPen, and there was reports of people looking to access EpiPens secondhand through various different online sources. So this does create some concerns with respect to patient safety. So that's a challenge, but it's also an opportunity. Because everybody does have a phone, obviously we're thinking about a scenario, maybe in a not necessarily a disaster where people don't have access to their phone, but a situation where people do have access to their phone in other scenarios where you can share information, provide warnings, where to buy, where not to buy, where to access other product safety information that I think consumers are going to want to look for in the event of an emergency. The other perspective I want to bring forward is on the manufacturer side. So yesterday, official from BARDA talked about, in the case of flu, for example, and a solution of setting up advanced market commitments to manufacturers, which is a great tool. Sometimes that might be to support large-scale manufacturing, but there are different technologies that are being developed, and something that should be commitment to develop those technologies that can allow for very rapid response. It might not necessarily be as high volume, but can support the rapid response and get within those few-week time frames. So I think the diversity in those engagements are important. And speaking to the predictive part of it too, I think the collaboration with industry to identify those threats early to allow for the scale-up is really critical. But again, relying on rapid scale-up technologies can perhaps give that extra lead time that's required to respond quickly. The third part on the Canadian side, so in Canada we also have a drug shortage list. We share a border, US-Canada, and there's an opportunity for us to work more closely together. We have a significant drug shortage issue in Canada as well, but there are manufacturing bases that support US and Canada together. So I think there's an opportunity to better share information across borders. We are doing it actually currently on the case of the EpiPen shortage, but there's opportunity to do more forecasting and collect that information and be able to utilize our manufacturing base that's shared across borders in the event of emergency.
That's great. And I like your example of people grabbing their phone really quickly. That could, in some circles, you might even be able to do some Google Analytics to see what are people searching for, and could that help be predictive. I also think about not only quality, but also that consumer perspective of a shortage. Many of you may know that one of the most popular blood pressure medications right now has been extensively recalled. This is the valsartan recall. It's due to the API being contaminated with a carcinogen. Many patients are looking every day to see if their drug is now going to be impacted. And it's very difficult as a pharmacist to explain to patients why they can't know why their brand of drug was manufactured with that contaminated API. And you can tell them a lot of information about why the drug companies want to keep it secret, but at the end of the day, they're curious about why they can't know what they're paying for, where it came from. So that's an interesting perspective. What else are we missing in this discussion about prediction?
One thing I would add, and it's to the point of prediction, but it actually is to a larger extent what we've talked about over the last couple of days, is that there are all kinds of challenges and issues from mapping back to source all the way through to how do we do alternate standards of care, and how do clinicians, or how does James change out the rigs every day, and what's a good best practice for that. And so I think, if I'm going to answer my own $10 million question that I asked earlier, right? If I had $10 million and can point to whoever's in charge, there are a couple of things. One is we need a research priority list, or a question list. What questions need to be answered? Where do we still have holes? And then categorize them. I mean, you have a whole room, myself included, full of academics that are like, we can help. Right? So let us know what the question is. So to me, if one of the things, and I said it to Keegan yesterday, if you could come up with that list, and then each of us who have an expertise that is slightly different, but we can partner, can say, okay, I know where I can get money from number 4 on the list. This group will tackle 4. I know where to get 6. This group will tackle 6. So I think that's part of it, right? I think there's this list that needs to be created, and then we can sort of tackle the pieces. I think the other thing is, from a prediction standpoint, if I could spend $10 million, it would be to build some analysis capability. And I think it's a hub and a network or a virtual system, maybe sits in ASPR or somewhere in FDA, where we can tackle this. Okay, Brexit's coming. What does that mean? Okay, Iceland's volcano just erupted. Okay, what does that mean? Like, to get to these predictable surprises, we need a unified platform that says, okay, how do we collapse together and get the right people within our consortium to start attacking this problem? I know jack about volcanic eruptions. I know a bunch about EPI and public health and disasters and supply chains. So, right, it's going to take me and a whole bunch of other people on the team to figure that out. So, but we need a connection point. We need a nexus. We need a hub. So, one of the questions that came through for our panel is, what should the government do? What should industry do? And I would argue that together, this is a public-private partnership discussion for predictability. We all have to be part of the team rowing. So how can we create that nexus or that hub? So that would be one thing. So if I spent $10 million, I'd spend it on those two things.
Excellent. Thanks for answering your own question.
You're welcome.
I think we have to anticipate the regulatory and legal considerations and again, going through the scenarios and what's going to be in place in that kind of circumstance. So for example, obviously very encouraged to see the FDA setting up this task force to look at shortages. One point that I know that the FDA made is that they might look to other jurisdictions to import in those circumstances. So obviously that's outside of line of what the FDA's perspective on importation in general. So thinking about, okay, well, would emergency be declared? How long would emergency be in place? Even there are cases if they were an import from Canada, we have shortages there too. There are certain specifications of certain drugs that are different in Canada than in the United States. So how is that going to be taken into account? So planning out the regulatory needs in that scenario is going to be very important. The other piece on the rapid manufacturing too, if we are going to use and charge technologies in an emergency scenario, what does the regulatory landscape look like in that piece? How does industry work together with regulators in that circumstance? And I know that BARDA and FDA has worked through this, but still it's a gap that needs to be addressed.
That's really interesting, and to the point about FDA working on imports, certainly they do import products even right now during shortages to try to ameliorate them. But to the predictive point, sometimes the products that they are able to import don't match clinical practice at all. It's a different strength or a different size or difficult to use, or the barcode doesn't scan. And so the companies that end up bringing in those imports almost get burned by bringing in the supply kind of at their risk that then doesn't get purchased or used, and often it's too little too late. So I'm really glad about the task force as well, and hopefully they'll think more about that. But it is can be difficult to predict, and it comes back to what is the known. Sometimes an import sounds like a good idea, but at the end of the day the logistics may not make it feasible.
I think now it's on.
Yeah.
I think we could also do more benchmarking of various kinds of ways to learn both what we can do to better predict shortages, but also what we can do to prevent, manage, respond, et cetera. And I think in terms of benchmarking, what the example you gave from the food industry is great. I'm not drinking any more hot cocoa at all. But there certainly are other industries where they have managed to overcome worries about proprietary information or fear of terrorist risk or whatever these things are. And so what can we learn from those other industries in terms of how they set up the structures and the resources and the data and the manpower to analyze that? I think we can look at more at other countries. So the example from Canada was great. So in fact, Canada is experiencing shortages. That makes you feel just a little bit better maybe, although it's still terrible that it's happening. And are the reasons the same in Canada as they are here? Is the UK experiencing shortages? Are the reasons the same as what they are here? And what does that mean for the longer term implications? Because there certainly are some market forces at play that over the long term can lead to greater risk of shortages, and thinking about that long-term prediction and better understanding some of those things would be useful.
So while we are still talking about mitigating shortage risk, I think we have to figure out ways of mitigating political risk. And we know we have countries that we have huge political risk with right now, even with the before the tariff wars, for example. To me, there should be some certain amount of important drugs or critical drugs, because it could be short, but maybe it's a device that you use, the pen, for example, that's not there. So that are made in the United States, and we can ramp up and have a capacity. I'm not saying that you should do everything here, but I'm saying we should be really seriously thinking about this, because with shortages that are occurring now, and we know that there's more volatility in the political environment. And I had just sent a student about 4 years ago to China to start beginning to look at normal political risk. He came back looking at how the supply chains were changing because of that political risk, to adapt to those environments. But if you have a political risk where we're cut off right now, we can't even fight a war, much less get drugs.
Sure, no, and I'm really encouraged after spending almost my entire career working on drug shortages. It's so encouraging to see so much attention to it right now. Your point, we do need to think about our supply chain and our drug supply as part of our critical national security. That's what I think. And I know there's a group in a couple of weeks that's definitely going to be looking at that. So it's important. How can we sustain our population?
With new technologies, and also think about we need to have reskilling of people to use those new technologies. So you can't just throw the technologies in there. So in terms of kind of changing the game, reframing the game a little bit. We'll always have to do the prediction, and all the things we talked about are correct.
Right.
But if something happens where somebody says we're just not delivering anymore, we're in trouble.
And to Julie's comments about global shortages, and I think your comments earlier about we also need to look at the root causes of the shortages. Honestly, there are absolutely global shortages in Europe and Canada, all over. And at the end of the day, the majority of those shortages are actually caused by poor quality and poor manufacturing at the factories. And so until we fix that root cause, I think we will be stuck in this shortage of basics. But anyway, we are getting very close to our end of our time, so I just want to give the opportunity for anyone else to chime in on anything we might have missed.
I think one thing that colleagues that we need to look at and bring here, and I know there are a few in the room too, is to, and we've started to do it at Minnesota, is to think about sort of the data science behind it. So getting back to root cause and knowing what's happened in the past, and then putting it into our artificial intelligence such that through machine learning, when we see that pattern happening again, that's where prediction will come into play. So we're doing it for food now. We say, we saw that fraudulent activity because of all of these environmental conditions that were happening. There was, a trade war, or there was some natural disaster. So let's now put that back into this supply chain because of Brexit, or because we're seeing some disruption in a particular part of the world, we don't get gloves. Well, all of those root causes then can be characterized through language, and then when we start to see information coming through that matches a pattern, we can say, wait a minute, could we predict that we're going to see a shortage because we saw it in 2007 and 2009 and 2012 because it has similar characteristics. So I think the next thing too, is to get a group of people who are working heavily in data sciences and apply, the epi, public health, drug, pharma, all of those folks together and start to build some smart, robust data science systems.
That's great.
One other thing around prediction, and we've been talking a little bit about the what. We didn't talk as much about the how, and hopefully there are people both in the room and elsewhere who can help make it happen. One of the things I think contributes to that is fully understanding the cost of shortages, both in the current status quo, but also predicting that future burden related to shortages. And so that's another area where prediction could be useful using data science. It warms my heart to hear you and others this morning as well talking about data science. But I think that that's really important so that we can translate into real action, both on the prediction side and in the other areas.
If I could just highlight for a minute, that's so important to know that cost, because getting funding for some of this work has been so hard because nobody, like, they're like, what's the ROI in you guys doing that work, right? So until we characterize it in dollars and not disasters, I think that we really need to put that out there so that we can find research money to say, if we do this research and build these systems and tools in data science, we will save, because this is what your cost is.
Dollars and lives,
yes,
of course.
dollars
Right?
and lives.
Absolutely.
But right now, what we're
Quantifiable.
hearing anecdotes, which people are like, oh, great, but we need to know what the cost is.
So I totally agree that we better put the dollar sign out there for everything and value that. One of the things I was thinking about besides machine learning and artificial intelligence in terms of some of this is also, I wonder, and I'm just exploring it right now with food supply chains, but blockchain, where you can actually, go through and follow through the whole system. Now, there's still no guarantee. There's always going to be somebody in there, and there's some issues. But we're looking at that right now at Clemson. One of my doctoral students is actually looking at that. So I'm wondering, it seems like it might work with pharma as well. And getting to the source and actually knowing that that product is reliable all the way through. And then I'm going to take one crazy thing, but it's I had data to prove, well, at least to raise the question. So some of the research that we've done on recovery, we've kind of taken an epidemiologic approach to, we took data from Thailand for 12 years, and we looked at floods at different provinces, and we found provinces that industrialized areas were more likely to not recover financially from flood. But there's lots of reasons to both. But then we decided there's variance in that, right? Not every one of those industrialized provinces is pure bad. It's not the average, there's variance. So let's look at the ones that recovered the best worst analysis. Which ones recovered, which ones didn't recover very well in that schema. And so we started looking at basic things you do as demographics, older people, age, gender, and we didn't find anything. And I said, my doctoral student, Grace, she's now faculty at University of Maryland, Grace, go find out what kind of factories there are in these different provinces. And sure enough, she says the ones that didn't recover were heavily chemical companies. So I said, okay, get the, again, go get the pollution data. So she went out and found that in the ones that didn't recover, there was more ozone and also sulfur dioxide versus the other is nitrogen dioxide, more dense population. Any rate, so then I said, let's look at, go through the medical literature now, and let's look at what diseases are specifically related to these types of problems. And it turns out that there's an array of them. I mean, an array that are medically documented. And so we then went through the best and worst case, and this is where we left it because this is more open, is that the worst case had, they were bad on every one of these indicators, the medical indicators. So, long term, you talk about dollar amount, we're talking about right now trade-offs in terms of our environment versus pollution, and do we need as many drugs if we don't have sick people? That's mine.
All right. Well, I want everyone, if we can give them a round of applause, and then we'll open it up for questions. And just please remember to state your name and affiliation when you ask your question.
Hi, thank you. I'm Monique Mansura with the MITRE Corporation. Wanted to follow up on two things. One, that Danny stated, this idea that we do all have our phones and look there for information, but also recognizing sort of the misinformation that exists as well. And many times those folks seeking to provide misinformation are more savvy, and those sorts of pieces of information get more attention and traffic. So how do you address filtering, getting the right information, especially in a disaster, especially in a situation where demand exceeds supply, and related to that, counterfeiting as well. It's one of the risks that we brought up in this report that's in our briefing books, the threats to pharmaceutical supply chains, that counterfeiting is also a major concern. So if you could address that. And then finally, just remind folks of ASIAS, A-S-I-A-S. It's the model in the aviation industry where sharing information about near misses, this has been going on for 10 years. It's the data analytics component combined with the ecosystem of having 100 folks with various interest in this space, sitting at the table and working together, learning from the near misses. Again, it's a highly regulated industry, it's a highly competitive industry, and it's international. So it has many good features that are very relevant. I'm done. So did you guys?
Thank you.
Yep.
Okay.
There is an app, I just saw it in Wired magazine, it's called SurfSafe, I believe, and basically, if you find that there's misinformation or whatever, you can check it. I know that's on the internet, I don't know about the phone, but it seems to me that that wouldn't be a bad app to have.
And it goes back to the point about the role of the federal government. So there is a role, I think, the federal government to get ahead and anticipate these scenarios and make sure to put information out there, public information as much as possible to help the consumer know. But the other thing is through partners through other organizations. So for example, the National Association of Boards of Pharmacy has a .pharmacy verification program so that the consumer can know if they go to an online site, they know they meet a certain amount of criteria and they can be able to differentiate it. But that information has to get out there, and they have to be pretty relentless about it, because as you point out, the misinformation probably will exceed the positive information that's out there.
Go to this side.
Prashant Yadav. I have two comments or questions for the panel. The first one is about advanced pharmaceutical manufacturing technologies, which enable us to reduce the manufacturing lead time greatly, and at least in theory, should be a good tool to reduce risk of shortages. And where do we stand in terms of federal commitments to advance such technologies, and where do we stand in terms of industry's investments in that vis-a-vis investments in new molecule development? So that's one question. The second is, if you look at shortages, I think there are clear event triggers, such as a hospital system changing its supplier, a supplier changing its manufacturer. That's when we see shortages becoming more likely. So presumably there could be a system which captures all such events, and there is some amount of competitive intelligence, so clearly manufacturers would not want to reveal, or hospital systems and distributors may not want to reveal who the suppliers are, but creating such a system should be, in a way, a federal and industry partnership sort of arrangement. I would like to hear a comment from the panel about what concrete steps do you think we need to take so that our prediction ability improves. I think adding the data science is the easy part. Building this system is probably the harder one. Thank you.
So I can't answer the question about the federal commitment or industry investments in advanced manufacturing, so if others can, but I'll pass on that one. Regarding the event triggers and building that system, so I think there's a practical list of things we need to do. One is data is, disaggregated, it's in different formats. I mean, anyone here from the CDC will attest to all the challenges we have about pulling, scraping data and getting it into one unified system. I think we're overcoming that, and I think there are lots of methods and tools now that'll allow us to do it. We're going to need commitment, and we're going to need funding. So somebody needs to be pointed to, and then a group worked on. So that would be the first thing is, how do we bring that data all into one platform? And there needs to be a sense of trust there. So how do we then come together? And there are a couple industry models I know that have worked for, as we talk about pandemics. Okay, we are willing to share these 6 pieces of information based on this trigger. So when we get to this point, we'll share. So how can we build those procedures and processes such that everyone feels that they can share in a trusted environment? Those are the first 2 steps. I agree with you. I think IT is the easiest. We can figure out the IT. That we have handled. It's really the policy and processes and trust that then allows us to implement IT.
To add to that, I think for those systems to work, the stakeholders also need to be able to see the benefit for them. You certainly have lots of examples of data sharing. I think about the Coca-Cola supply chain sometimes, and Walmart and retailers are sharing information back up to Coca-Cola. And some time ago this would have been unheard of because that's proprietary information. And then what if it accidentally got out, and what would that mean for Walmart's competitors if some of that information made it back? but eventually the stakeholders have seen that there are improvements on all parts of that supply chain, lower levels of inventory or lower cost involved, fewer shortages through that information sharing and visibility, so that greater opportunity for market share and growth for those stakeholders. I don't have an answer about the federal commitment, but hopefully ASPR, BARDA, FDA, CDC, others will, but I will say that right now, the focus is on prediction, partly because the system is not an agile, adaptable supply chain. If you have a supply chain that is more agile, adaptable, aligned is another part of that, where the incentives are aligned across that supply chain, then the need for prediction and managing the supply chain is decreased. And so certainly advanced manufacturing techniques are part of that solution, just as you said, rapid scale up for some other examples. So that definitely is part of that solution.
Manufacturing piece. So with respect to U.S. government investment, there's been significant investment to address advanced manufacturing in the context of emergencies. So under HHS, there are Advanced Development and Manufacturing Centers, and then a similar type of program under Department of Defense. There still are gaps, though. If we look at influenza as an example, HHS has been very public in terms of their commitment, or their goal, rather, to, within 12 weeks of a declaration of a pandemic, to have a vaccine filled. We're still not within that time frame, and so there's still a gap with respect to manufacturing technologies that can be utilized to meet HHS's goals, at least with respect to pandemic flu.
Yeah, Doug Throckmorton, FDA. I'll just take the chance to respond to the manufacturing question. FDA has an advanced manufacturing analytics and process improvements team. Somebody wants to talk to us about new ways to be more efficient at manufacturing products. I can give you a name now. So terribly important, something we absolutely understand we have to do. Second, my comment has to do with the importance of prediction and predictive modeling. And I think you nicely unpacked a lot of the challenges around data sharing and those kinds of things. There's one other element. So as we start thinking about what criteria you might put into an analytic model to identify a list of products that you're going to do something about. You anticipate there is some increased risk for shortage, either because of natural disaster risk, they're in a place that's prone to, I don't know, volcanoes or cocoa disruptions or something like that, whatever that is, or because they're at risk because of manufacturing challenges of one kind or the other. As you think about those criteria, you have to think a little bit about how many products end up on your list. Because if your list ends up with 500 drugs, and your expectation is that all 500 of them are going to do something, that's going to be a different kind of burden. Maybe 500 is the right number, versus a smaller number that then you could potentially be more sort of impactful and sort of make a difference in terms of the things you do. So that makes it a little harder to just identify the group, and it makes it a little more important to sort of think about those criteria really carefully.
I think that's a really important point, and I think Keegan brought it up yesterday, that's one of the tasks within the task force is what are the critical ones and how do we prioritize which ones to look at first to go back to raw materials. So we did it with post-Ebola, and we went back with WHO and looked at, okay, what are the 62 most critical items for the PHEX, the Public Health Infectious Diseases of International Concern, or whatever the acronym is for that. And we said, okay, what are the top 62? And we looked at that from a disaster humanitarian perspective. We looked at it from an ER doc perspective. And not everything on the list is a drug. Sometimes, right, it was an ambulance or a tent or something else. So I think we need to get to that point and come up with that list and then be able to go back and do some of this analysis. So, the list is really hard, depending on are we talking about chronic? Are we talking about acute? Are we talking about terrorism? Are we talking about disasters? So the list may change a little bit depending on the region or the population. And so I think there's going to have to be a lot of work to sort of assess that list. But I wholeheartedly agree that we're going to have to collapse. And I think, the comment this morning about Haida's work and doing Linda said, first we did needles and now we're doing gloves. We'll get better as we continue to go through these.
struck by how exciting that research you guided your student through was, and what a good example of starting at one place and discovering what needed to be done next. And I'm reminded that many people in this room may have students maybe doing research. It's a mix of government, industry, and academicians. And as Americans, many of us think that it's only our government, our Canadians, it's only our government that care about us and about our health status. I work quite often with colleagues from out of the U.S., and one of my colleagues is Norwegian. He knows the Ministry of Health in Thailand and has been working in Thailand with them and with some projects for more than 10 years. And they're very concerned about their people. And the follow-up, I have students, I usually have undergrads, but part of what I feel is my obligation is to teach them that last step that they might not do. And so it could be that for more research for all of us, finding a contact and picking up the phone and saying, the risk of these diseases showing up in this time frame is this. And so just an observation that we all do research, and sometimes there's this other step that, so thank you. And thanks for, and thank you for that good example of good work.
One last question.
This is prediction. I went home to the hotel last night and thought about if I wasn't the Commissioner of Health for Connecticut, and I was sitting in that audience, and I was a millennial who was entrepreneurial, could I get needles quickly? Because I had heard, sitting in that room, that there was going to be this big problem. And I went online, and I did not order it because my Amazon Prime account, my husband would have gone ballistic. But I was able to solicit over 100,000 needles and syringes that were shipped from the United States, that were known people, known products, within 22 minutes. So if there were 100 people who did that, all of a sudden you have 1 million syringes out of the market. And what I don't know, and I think as we look at predictive modeling, is if I'm ordering that, does my order get the same exact criteria from McKesson or wherever else it's coming from, or wherever warehouse it's coming from, as the hospital in Connecticut? And then, you know, the governor doesn't know I have this in mine and 10 friends' garages until the state police finds out. But I feel like there's this, with Amazon, there is this whole other supply chain that exists separate from what we all think of as our traditional supply chains. And in our country, it has to do mainly with kind of masks, supplies, things you don't need a prescription for. But I can go on Amazon Mexico and order a large number of drugs. And so how that will, for lack of a better word, screw up a lot of our planning and our predicting, I think, is going to be really important to think about.
Those are great points, and I know I'm between you all and lunch, so. All right, let's do one more.
To that point, I think we have a couple comments.
Well,
One I would say is so we saw that, like one thing that we came up with out of our Ebola work is we need referees to sort of manage. And what we saw in Ebola, we were trying to find data anywhere we could to see who's buying from who and what. And one data set we were able to find, and we were looking at body bags and gloves. And we found, wholesalers and distributors buying from manufacturers, and we found USAID and DFID buying from them. We also found individuals buying large quantities. And so the only thing we were making assumptions interpreting is that these were individuals that were self-deploying or deploying within a small organization, but they were purchasing and then bringing them with them. They were US citizens bringing them with them into Africa. Well, who's refereeing that individuals get to pull down on our critical supply and WHO doesn't get access to it because, 5 docs or nurses who want to do good, God bless volunteers, but now we've lost control of that and our shortages were. So to your point, I think we need referees.
Hi there, Anita Patel from the Centers for Disease Control and Prevention. So the comment you just made is spot on. This is what we saw during the Ebola response, where we had complexities in the supply chain and lack of clarity on what the actual true needs for product were, we had minimal cases in the US, but we had a lot of planning and preparation and panic ordering. So as you're thinking through predictive models, one of the approaches that we've taken on the CEC front is to put factors in that start considering human behavior. So we saw it during H1N1, we saw it during the Ebola response, where if you're not factoring in the panic ordering, and then if you're not putting systems and processes in place to right-size those ordering patterns during a response, that's what's going to become totally problematic. And the modeling for respirators, for example, that we've done most recently actually factored in two key aspects. One, the panic ordering, and two, the need for constant product. So I appreciate the models that were presented with the last panel where you're looking at epi curves to determine what the product needs are. But in some instances, especially in the personal protective equipment space, you're going to require constant demand as part of the model versus an epi curve model. So understanding that and understanding that you may not see disease, but every single person in that ER is going to want to have and demand to have some level of protection, especially in the absence of vaccines or other medical countermeasures that could be in use.
So three things. First, community preparation and local preparation is key. Everybody should have masks at home all of the time.
Yeah.
You know, I have a mask. I don't have an Ebola suit, but I do have masks at home.
Maybe for Christmas.
Yeah. I did give disaster kits for Valentine's Day one year.
See, there we go.
That's how you show you really
show
love
you
someone.
love. Yep.
That's right. Secondly, prediction models have to account for behaviors and panic ordering, as you say. You also need your distributors and manufacturers to have some control over the process. When I ordered masks after H1N1 was hitting the news, Amazon said they would get them in 2 days, but then I got an email that said, oh, sorry, we don't have them, we were just kidding, you know. So I assumed that they were going to government hospitals or NGOs that were higher priority than I was. Third, having relationships with those manufacturers and distributors ahead of time, relationships for the government organizations and the hospital purchasing organizations is crucial. International NGOs have frame agreements where they have certain contracts in place on what an organization would be able to supply during a disaster, but then also being able to go back and look at the data later so that your future predictions are more based on true need, as you say, true demand and assessment of that, not just past orders, which is not the same thing as demand.
Yep.
So it's almost impossible for the manufacturer to be able to predict what the needs are and manufacture and ramp up, and they can cancel orders. So the risk space is massive from a manufacturing capacity standpoint versus on the pharma drug side, where it's much more regulated, it's much more linear. So what changes can we make in these different supply chains, and what do we need to consider in order to be able to augment what we do in supply? I think from the other panelists.
All right. Well, if I can get everyone to give our folks another round of applause. I want to thank all of you.
Very good discussion. I was really appreciative of the diversity that we had here, and nice segue, I think. It's lunchtime. Come back at 1 o'clock. Sheldon is going to lead another team to talk about prevention approaches to this, and we may back into this supply chain demand side curve on the prevention discussion as well. So don't let this drop. Go get some nourishment and be back here at 1.